And we are live. Hello, web shadowers. Thank you all for joining our session today. Today, we have the pleasure of hosting Dr. Grossman, who will be teaching us about internal medicine and pediatrics. As always, please remember the Google form will be posted in the chat box and in the description of this video at the end of the session. And please stick around for an announcement about our April Roundup that's happening this weekend. With that being said, Dr. Grossman, you can get started whenever you're ready.
Hey everyone, how you doing? My name's Jeremy. I am a resident physician in the fields of internal medicine and pediatrics. So I work with adults, big people, and I work with pediatrics, which are little people. That means kids. I see people of all ages, sizes, shapes, diseases, conditions. It's a lot of fun. It's a big reason why I chose the field. I'll go into that in a bit. I'm originally from California, so I went to high school out there. And I went to the University of California at Irvine, and I majored in biology, and then I thought I was going to be a therapist, so I ended up getting a psychology degree as well. I don't think that's normal by any means, so don't feel the need that you have to get 2 degrees. I just was super indecisive. And so I did that, and I took a year off. I did some tutoring. I studied for my Mcats, which are like the SATs for medical school. And then I went to medical school at a place called the Sackler School of Medicine, which is out in Israel. It's got a nice connection with the state of New York. So it's kind of a weird program where it's boarded by the state of New York. So it's technically a New York medical school, but it's not like a US medical school. So we have to do some things that international people do and some things that the US schools do. So we're kind of an in-between school, but ultimately a lot of us come back to New York and we do residency here. So after medical school, every doctor has to train and be a resident for a number of years. So there's different specialties like dermatology, internal medicine, pediatrics, surgery, obstetrics and gynecology, neurology, neurosurgery, you name it, there's a long list and a lot of great things to choose from and a lot of overlap between a lot of those fields. But ultimately I chose internal medicine, pediatrics, and I'll get into why I did that in a second. All right, let me see how this works here. All right, so I put a Q&A here, but I think it's too early. All right, so my role now is I am a senior resident. So what that means is there's people who are interns who just started their residency, just graduated, and during their first year, you're just kind of learning what a doctor does beyond what you already learned in medical school. And that means like dealing with social work, calling families, determining kind of the flow of how you're ordering tests, labs, imaging, treatments, etc. And then you become a senior. So your last few years, you're technically a senior after your first year, depending on what specialty you pick. So because I'm doing what's called internal medicine pediatrics, which is 2 careers, I'm going to be double board certified in adults and kids. As a second year, you become a senior, and in some programs they wait till you're like halfway through your second year so that you can figure out, excuse me, sorry, I'm still getting calls, I was at work today. You can still kind of figure out what it takes to be an intern, what it takes to be a good doctor, because there's a big learning curve even when you're just doing one specialty, so doing 2 can be really difficult as well. I live right now in Long Island, New York, and I'm doing residency out here right now. Again, originally from California, so I'm definitely a long way from home. Any fun or interesting qualities? I have a dog, Zeus. I play guitar. I play some other instruments. Zeus is sitting in front of me right now. If you guys want, I can show you Zeus at the end of the video. He's not the main topic of today's chat, but he's the main topic of my life chat. Thank you, Sophia, loving the dog pic. All right, here we go. Or maybe that was somebody else that sent that, right? Because it comes from YouTube. So somebody else, thanks for saying they love the dog pic. That's Zeus. All right, so this is my hospital where I work. As I told you guys, I grew up in California. I actually am a type 1 diabetic. So what that means is my pancreas is broken and it's not producing some hormones that I need to survive. So I have to supplement myself and give myself injections. And to take it further, I actually have a cool pump system that gives me those injections throughout the day. So most of you have probably met a type 1 diabetic in your life. And if you weren't aware, you definitely did, because it's a very common condition. I told you guys where I went to school at the University of California. went to medical school in Israel at the Sackler School of Medicine. There's also a lot of great options. If, by chance, some of you guys are seniors in college and you're applying to school, let's say maybe you don't get into that US school, there's also DO schools, which are available to you as well, which are very similar to MD schools. You just basically learn what's called osteopathic manipulation. And it's actually what chiropractic came from. So I recommend DO schools as well. I have a lot of good friends who are DOs, and it's a really cool option if you're not able to get into those USMD schools, because they tend to take lower GPAs overall, and it's a little bit less competitive to get into. So I definitely recommend that, and I applied to those schools as well. And then on top of that, you also have international MD schools. Very common, you guys probably know about, are the ones in the Caribbean, St. George's, Ross, AUC, stuff like that. So those are all really good options. If perhaps it doesn't work out in the US, but maybe you just want to go to the Caribbean and go to med school there too, and that's fine. I love my international experience in Israel. I wouldn't change it for the world. If you asked me if I wanted to go to Harvard, I would say heck no. I really enjoyed it. It kind of made me grow a lot more as a doctor, as a human, most importantly, which will be a big part of my talk today. So I basically ended up seeing what it was like to be a kid with diabetes, an adult with diabetes, and I kind of understand what it's like to be a patient throughout that time. And all of that time is super important. And that's what led me to pick this field in internal medicine, pediatrics, combined residency. You also have family medicine, which is similar to med peds, which is short for, internal medicine pediatrics. But med peds is typically more inpatient, meaning it's more in the hospital. It's more acute care, people who are really sick, right? If you're dealing with outpatient medicine, it's usually people with like 1 or 2 problems. They're not super sick. They don't need to be watched in the hospital. So that was the kind of the difference. I realized I really like hospital care. I really like the acuity. I like doing ACLS, BLS. I like saving lives, living that more action life, and making a difference in people's lives in really acute, quick settings. Somebody said, what's the name of my medical school? It's called Sackler, Sackler, Sackler. It's like slacker, but you move the L around. But we're not slackers, we work hard. All right, let's move on here. So why medicine? I kind of told you guys, I've done a few of these talks, so I start to lead into my next slide before I go to my next slide. Ultimately, I chose medicine because I was a diabetic, and all of you are going to choose medicine or PA school or NP school, or you want to be a tech, like a echocardiogram tech, or maybe a CT tech, whatever it is, whatever your reason to go into medicine, that's totally up to you. And if it's what you want to do, please do it. My reason was just my own. I had a relationship as a patient. I understood the importance of the impact that my doctors and healthcare team made in my life, and I wanted to do the same for others. But you're all going to have different reasons of why you went into medicine. So I'm going to ask a question. Since you will be double board certified, can you do a subspecialty in any of the 2 branches, i.e. go to neonatology or go to a branch of internal medicine? Yes. So family medicine, you're only boarded in just family medicine. You can just go down that path. And there are some things you can go into ER, you can go into hospital care, you can go into like sports medicine. There are a few different things, but med peds, you can go into so many specialties. You can go into all the specialties of internal medicine, all the specialties of pediatric medicine. And you can also actually be double board certified in both later on. So if I wanted to be an adult cardiology person and a pediatric cardiology person, I could do that. I could create a residency, a fellowship program, and go work at a hospital and try to finagle and get a fellowship made to be applicable to me as a med peds doc. A lot of us just go into one field, and a lot of us don't even do fellowship. We'll just go into residence. We'll go into rather primary care, or we'll go into hospital care. I want to be a hospitalist. What's really cool about being a hospitalist in the adult world is that you can work part-time in the ICU. I love critical care. I love ventilators. I love helping people get out of really sick times. I like being there for families during the most stressful times. I really enjoy making that impact in people's lives. And I really like the impact that you can have in such a short amount of time. So that's why I'm interested in being a hospitalist. I have a lot of respect, immense respect for primary care physicians. And I just came from primary care clinic today because all residents have to do some primary care in an office setting and some care in an inpatient hospital setting. So you have to do both. You have to be trained in both because you can ultimately go into both fields, right? So ultimately I chose, or rather I'm choosing to go into a hospital field because I enjoy it so much more. Okay, so all right, so it's the same question, okay. All right, so that's why medicine. Let's move on a little further here. All right, NAMPRA. So I want to give you guys something interesting. So a lot of you, probably like Sophia, who's the host today, you're in college, you're doing a major, but a lot of what you're doing may not be medicine related. And you might be like, okay, listen, I want to learn some medicine. I'm interested now. And I love that. You should totally do that. But first comes first, you have to pass your classes. You have to get a good GPA. That's like the most important thing. If you get a bad GPA, is at the end of the world? No, you have options like international schools that will accept you, but you're going to be paying a little bit more because you're essentially paying your way through medical school. Now, is that to say that those people are worse doctors? Heck no. Some of the best doctors I know went to international medical programs. And I'm not saying that because I'm an international medical graduate. I know better doctors than me who have really good work ethic and have been through tough times. And maybe they couldn't get the best grades they did because they were going through kind of a life issue or a life struggle or family issues or their own medical conditions or whatever. So there's nothing wrong with doing the international route. Now, that being said, you get good grades, fine. But what you have at your fingertips now are these really cool websites for medical students, for residents, for like myself, and for college students that are interested in medicine. And you have websites like NAMPRA, which talks about, has a lot of cool resources to learn like cool tips and tricks, little factoids about medicine, which I think is really interesting and fun. And not only that, you can kind of expose yourself to the field and say, hey, is this the right move for me? When I ask my people who I'm mentoring that are either medical students, pre-med students, whatever, interns even, to figure out what they want to go into, I tell them you have to go check out your resources. So if you're interested in surgery, go email a surgeon, go into Google, type in, hey, type into Google, say, general surgeon near me, type the first person, see if they have an office number, call their office. Hey, I'm so-and-so, I'm a medical student. I'm looking to find out more about the specialty. Would there be any possibility that I can come shadow you? And hopefully they say yes. And if they don't, you move on to the next one. You email 10, 20 people until you get it. Okay. There's a lot of programs that have been made that you can kind of join in and apply to. And I did one of those and I didn't have a good experience with it because ultimately I was just like delivering towels and cups of water to patients. Meanwhile, my dog is like rolling around. So if you hear scratching, just, let me know if it's too loud. All right, he's getting up now. Maybe he'll be quieter. I don't know. Okay, so you have NAMPRA, and even more importantly, I recommend a website called AAFP.org, the American Association of Family Practitioners. You see a lot of cool stuff. I recommend these two fields because internal medicine, pediatrics, family medicine, it spans all ages, all types of medicine, and it's a good way to intro you into medicine. So even if you want to be a surgeon, you got to know the medicine basics at the very least. So please, if you don't know exactly what to shadow at this point, or you don't know what to look into, just look at general medicine, figure out if it's what you want to do. Because all of us, whether we're surgeons, neurosurgeons, dermatologists, OB-GYN, whatever, you have to know general medicine because that's where you're practicing medicine, right? Even though you're specializing in a field. Okay, so NAMPRA and AAFP.org. A question came up. Can you explain the difference between hospital medicine and internal medicine? Internal medicine is just the medical management and treatment of adults, okay? But a treatment of adults can be in a hospital setting with acute care management, where patients need help, they need to be monitored on cardiac monitors, pulse oximetry, et cetera. But you also have adults who just say, oh, my back hurts, I need to just go see a doctor, all right? And the tons of other issues, a huge amount of issues, but those issues don't need to be in a hospital setting. It's not acute emergency. It can wait a week if they need to see the doctor. That's outpatient medicine, and that can be internal medicine as well. My specialty is kind of confusing. So I want you to think of me as both an internal doctor and a pediatric doctor. I just do both, but there's no like weird overlap where I'm doing something different. I'm really just doing both fields. So I don't want to confuse you guys too much. So that's really the difference. You can work in a hospital or in an outpatient setting. And even if you go on and specialize more, let's say you go on, you want to be a rheumatologist, you want to work with joints specifically. You can do that as an inpatient or an outpatient. There's so many options. It's nuts how much you can do in medicine, and it's a really fun field, and it's really awesome. And again, there's also great specialties like PA school, like NP school, tech school, etc. There's a lot of cool things. All right. Next slide here. Let's see. All right. So I kind of told you what a med peds doc is already. I kind of told you what I do. I can do anything a pediatrician does, anything a adult doc does, anything in the hospital, anything outside of the hospital. I work in ICUs. I can work in the ER. I can work in general floors. I even work in the NICU, which is little baby ICU. So I go work with any age, any population, any severity of illness. I'm going to see them. And I love every minute of it. And that's why I want to work in the hospital, so I can move around and do it like that. I want to be almost what I call a resident for life. I love rotating. I love the diversity in what I'm seeing. A lot of people, they just want to become specialists, and there's nothing wrong with that. And if I have a problem with one specific thing, you bet I'm going to go want to see a specialist, right? Because they're really well studied, well practiced, and they can talk to you and help you with that one issue really well, right? So some people want to do that. It's not for me. I want to kind of be a jack of all trades, or I hope to be almost a near expert in all trades to some degree. And I want to do everything I can for the patient, but be able to say, hey, listen, I don't know what I'm doing at this point now that the patient has this, I don't know what I'm going to do. So now I'm going to call for help. I'm going to call those specialists. I'm going to call the consult. I'm going to send them to another doctor, see if I can help them out in another way. Okay. Rock and roll. All right, I think we have all the questions because Sophia's updating them. So I'm just gonna rely on Sophia to update that chat for me. All right, so we kind of talked about kind of how much it takes to be a doctor, right? Like being a doctor and going into medicine is a long field, right? So most of you, I think, are either in college or you're in high school. All right, so I was there like 10 years ago. So I'm almost 29 next month. Okay. So, this was me 10 years ago, which went by like that. I feel like an old dude now. Like, I feel like I'm still a high schooler, which is crazy, but I did all of this. So let's go through it together. So undergraduate education, also known as college, you got to go to college, right? You got to get that basic degree. You got to get that basic science knowledge. Okay. I'm going to take a sip. Hold on. That's good water. You're going to go to undergrad education, right? You're going to major in probably bio, but you can do really any science as long as you have your prerequisites for medical school, meaning you need to take a few basic classes for medical school. And then after that, you got to take your Mcat, okay? The Mcat is kind of the SATs for medical school to test your basic science knowledge. And most importantly, your science GPA is the most important undergrad, okay? So you got to work really hard. If you get a bad grade, it's not the end of the world. If you don't get the best GPA, it's not the end of the world. You still want to be a doctor. You still want to work in medicine. There's a lot of options for you, okay? Like I said, undergrad, DO, you can be a PA, you can be an MP. You can do a lot of the things that we're doing as doctors, just with two different initials, and the patients still love you. It doesn't make a difference, okay? It does not make a difference. And if you think, and I have to say this too, every talk I make, if you think that the only way you can be a doctor is go to a US school, and like a prestigious USMD school, then I don't want you in my field. I only want people in my field who really care about their patients, who don't care where they go, who don't care about those letters. All they care about is helping the patients and going into the field to make a difference in people's lives. Okay. So if you're on this call right now and you say, I'm too good for international, I'm too good for DO, I'm too blah, 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 then I don't want you in my field. Then go pick another field, go into like business or something, go make money. There's a prestige in there you can get. This is about the patients. This is about making a positive difference in people's lives. So you have to be open to everything. Every single one of you should leave today and you should be thinking about, I'm applying, let's say next cycle for school. I want you to apply for international schools and DO schools too. They're all the same. We're all treated the same, okay? We are all equal and we're all making a positive difference in people's lives. And guess what? We all respect each other. I work with all types of doctors and I appreciate and respect them all equally. And guess what? It doesn't make a difference. And the only people that it makes a difference is are the people that went into the field for the prestige, okay? Just remember that. That's my preach to you guys for today, okay? All right, so after undergrad, you go to medical school for 4 years, unless you're like a super whiz and you're in a BS MD program, meaning you go for a 4-year and plus 2-year combined bachelor's, undergrad, and medical school degree program. So usually coming out of high school, that's pretty tough to do. You have to have really good grades, and I'm not sure how many of those there are. The ones that I know in my life that I know that did that are very intelligent people, and I commend them for doing that. But the vast majority of you probably won't end up doing that because it's so difficult, okay? So the first 2 years of medical school, you're working in general, you're just learning the basics. The last 2 years, you're really getting your hands and your feet wet. You're going out there and you're working with patients, learning how to do medicine. Then residency, it says 2 years, but it's usually like 3 to 5, 6, 7 years, depending on if you go anywhere from pediatrics to like neurosurgery. And then you have fellowship, which is, it says 1 or 2 years, but it should really be like, a lot of cases it can be anywhere from 1 year to like 4 or 5 years, depending on if you want to be like a interventional cardiac surgeon, blah, 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 something really big like that. So if you're interested in only one aspect of medicine, go online, do your research, see how long it takes to get there, and just be aware of it. But I don't want you guys to stress too much about the future. If you look 10 years in the future, you're going to go loco in the cabeza. You have to really be cognizant of just day to day. What am I going to need to do to the next day? What am I look a month ahead? What do I need to do to get to the next month? What do I need to do to get to the next semester? And just do your best. And if you can't, if your best isn't enough, that's it. That's okay. There's other options for you to help other people. I tell people often that if I didn't go into medicine, I would have opened up a dog shelter and just played with dogs all day and got like funded and you know, lived a very simple life, but I would have felt really good about what I'm doing. If you tell me you think that being a doctor is the only way to give back and make a positive difference in my, you know, in anyone's life, I think that's so wrong. In fact, I think the doctor field, we get paid a good amount of money, so it's really hard to say we're doing it all for the patients. Is that to say that we don't care about the patients? No, but it's just to say that there's a lot of really respectable fields out there that I don't think are getting enough credit. And if you don't end up going into a medical field, I think that's totally fine. I still respect you, and I think it's really cool. In fact, whenever I have the time, I love asking my patients about their lives and what they're doing, because a lot of them lead really, really interesting lives. All right, somebody asked, how long will my residency be in total? So I'm a 4-year residency. Normally pediatrics is 3 years and internal medicine is another 3 years. So that's 6 years. But what we do is we do this combined accelerated program, which creates a 4-year program. And we just do intensive inpatient medicine. And we do outpatient medicine as well in the clinic, but a lot of inpatient medicine. And we find out that actually a lot of the, even as little as a baby ICU to an adult ICU, there's a lot of similarities in ventilators and drips. There's just different dosing and different kind of mechanisms of what's going on. So ultimately, it's pretty cool. It's pretty cool what I'm doing, but it's a big learning curve. I'm always reading. I'm always behind my peers because my peers are just doing one career option. So they have to just know that, but I have to know two. So I have to always be on top of my game. It's a lot of pressure, but I love it. I love what I do. I'm very interested in it. And I know that one day I'll be at, where everybody is at around me, and I'll be practicing. I'll be making a really good positive difference in my patients' lives. Okay. All right. Another question. For step 3, I heard some students take it before residency years. I thought the exam is specialized for whatever residency you got in. So how can you take it if you are not in residency yet? So ultimately you have to to my knowledge, you have to graduate medical school to take step 3. So before you get to medical school, you take kind of the SATs of medical school, which are Mcats. Okay. And the Mcats is just a one score, like an SAT, to see, okay, here's their GPA and here's their like basic medical score. How do they perform under pressure? You do that also 3 times before you go to residency. But step 1 and step 2 are usually the ones you take before residency to find out where you go to school, because the residencies really care about those grades. Recently, they made both of those pass, no pass. So except the step 2. So basically, there's a lot less pressure surrounded by that. And I think they're trying to look for more holistic candidates, look beyond the grades, see what they did beyond their classroom learning, to see if they're already trying to make an impact, right? In medical school, I created this organization called the Homeless Project, and we would go out, we would feed the homeless, we would survey them, ask them how they ended up there, and give them resources to figure out where the best place they could go for help was. And it was a super rewarding experience, and I was making a difference, and I wasn't even a doctor yet. And I would argue that I've made a huge difference then, probably more than I have now. All I'm really doing now as a resident is kind of being selfish, right? I'm making a difference in my patients' lives, sure, but I'm really just here to learn for me. So, it's a give and take, but ultimately you guys can make a difference in people's lives now. And that's why I say, you don't have to go to medical school to make a positive difference in people's lives. You can do that in other fields as well. And I really encourage you to do so. And guess what? Medical schools love seeing that on your applications too, okay? So step 3, everyone takes the same one, and it's usually in the last year of school, and it's just pass, no pass. It's not really that big of a deal. Okay, so here's myself. Here's some other med peds docs. The one in the middle is an ICU. She's PICU trained, so pediatric ICU, and she's also trained in palliative care, so end of life care. It's making people comfort care and making sure that they're living the best quality of life in their last few days. The other two on the end are my interns. So what is a typical day in my life? So this is a really important part I want you all to hear. I don't think I listened to this. So if you're if you're texting, if you're on TikTok right now, if you're on Twitter, just take a sec, just listen to this 1 minute part of the speech, because this is the most important part. I wake up, all right, at 5 o'clock. I have a dog, so I walk my dog. Maybe some of you have kids, maybe you have family got to take care of. That's what I do. I have breakfast, use the restroom, have some coffee, and then I drive. I live about 30 minutes from my hospital because I love the area where I live in. And I drive 30 minutes to the hospital. And I get to the hospital, it's about 7 a.m., okay? So it's like, I could probably wake up a little later, but I like to sip my coffee a little slower. So we'll call it 5:30. So that's an hour and a half I wake up before. And I don't have much prep. I just come in looking like this. So take it or leave it. Then I go to the night resident. So there's always a doctor at night who watches my patients for me. And one day I'll be the night resident. We'll switch. I'll watch patients for them, and they'll, get the patients from me in the morning. So I say, night resident, what happened overnight? They'll say, oh, this patient had this patient had this. I got this test. I got this lab, this, So I go, okay, thank you so much. Have a good one. They go to sleep. I go see my patients. I chart review. I look at all my vitals, my labs, my imaging. And I make a decision, okay, what's the plan for today? Should this patient go home? Should this patient stay longer? Do we need to upgrade this patient to an ICU because they're getting really sick? I make all these decisions. At 9 a.m., my attending comes around. So they're the head honcho who's already done residency, who's been in the business, who knows their stuff. And basically my job is just to go around and see all the patients with them and just present to them and say, this is what I think we should do. This is what's going on. And they'll say, okay. So I agree with this. I don't agree with this. Let's do this. So I do that. I put in my orders. I write my notes. Next patient. We do that for maybe 3 or 4 hours. We see all my patients. I go get lunch. And then in the afternoon, I finish writing my notes. I go talk to my patients. I call families. I order more tests. I order more medications as little images and findings come back. And I respond to rapid responses. If somebody starts to decompensate, they're having trouble breathing, their blood pressure drops, whatever. So I'm responding. And then at 7, the night guy comes back, or the night gal comes back. I send out the patients. I go home, take a deep breath, come home to Zeus, drive a half hour, and we go on a walk. I have some dinner. I watch some Family Guy. I watch some Bob's Burgers. Solar Opposites is a really funny cartoon show now. I like to watch the boob tube when I get home, because my brain's been frying all day. I needed to be in the refrigerator for a little bit and let it cool down. And then I go to bed, and that's pretty much it. And so when I'm on an inpatient hospital rotation, I'm doing that for like 6 days a week, okay? So, and those are like 13, 14-hour days. And then on top of that, I'm also doing research. I'm publishing a paper right now. I'm also doing volunteering. I have to call family. I have to catch up on projects that I'm doing, quality improvement. There's a lot going on. It's not an easy path. That's why I'm saying it's not all about the prestige. It's not all about the Grey's Anatomy walking down the hallway, looking pretty with the lab coat flying in the wind. It's really more than that. Like, I'm really walking down the halls a very small portion of the day. And most of the time I'm sitting on my computer like this, doing work, thinking, working hard, doing a lot of repetitive activity, tired, drinking a lot of coffee or water, because it's my day off today. Or my night off. I got off a little early because I was in clinic today. Somebody asked, how many hours a week do you usually work? All right, so somebody do the math. I mean, if I do 13, 14 hours a day, 6 days a week, let's see. I can't do that math right now. So let's say 13 hours a day, 6 days a week. All right, so that means I'm working 78 hours, okay? 78 hours a week, like an 80-hour work week, give or take, okay? When I have an ambulatory week, meaning when I'm just outpatient in the office, it's a little less, maybe closer to 60. But most of the time you're working your butt off and you get used to it. I'm just like, when I'm not tired and I feel rested, I'm like, what's going on? This feels weird. But you get used to it. And ultimately, I love what I do. So it's not all a loss. I'm not tired and depressed all the time. And it was very difficult when I first started to get used to, but after a few months, you get used to it, you work hard and you get better and you start to enjoy it. And then when you get to my position as a second year, and I'll be a third year in about a month or two, I'll be helping other people, improve as doctors, learn to be doctors. I'll be working with medical students, teaching them, and I'll be getting ready to be my own attending in another 2 years. So it's all part of the journey, and you're always growing and learning. And just when you get too confident and you think you know it all, you really don't. You get reminded quick, and it really humbles you a lot. Okay, so that's the day in the life. All right, so those of you guys can go back to TikTok, Instagram, Twitter, if that's what you guys were doing. That was my most important part. Okay. All right, any questions? Okay, someone asked, what research am I doing right now? I am doing research on COVID and asthma. So during COVID, we all were wearing masks. We all were not interacting with each other. We were in isolation, and ultimately we weren't really spreading viruses around, including COVID, right? So a lot of the causes of asthma are viruses. You get a virus, it activates your inflammatory system, and basically everything gets inflamed, and you have an asthma exacerbation. So the asthma rates drop like crazy. A lot of diseases and virus and presentations of illnesses that are caused by viruses and infectious diseases dropped pretty drastically during COVID because we were all isolating. So mask wearing really does work. Isolation really does work. It's not the funnest thing. I don't like isolating. I'm a very social person. But ultimately it worked, and it's what we needed to do, and we're getting to a better spot. I hope all of you, if you're not already vaccinated, you get vaccinated soon. And yeah, that's what my research is on. So I'm actually if you guys want to see, I'm publishing an abstract right now in Pediatric Academic Society, so you can look me up. I've also published a paper on adherence to different medical therapies in diabetics, in type 1 and type 2 diabetics in the adult population. So I've kind of been all over. I do all sorts of things because I love it all. Again, back to med peds. I love everything that I'm doing. I'm very interested in everything, and that doesn't mean you have to be, but that's what I'm interested in. Okay. Let's see, other questions. Are hours better as an attending? 100% hours are better as an attending. I think the attendings that I work with are like 9 to 5. If you're a hospitalist, meaning if you work inpatient on the general floor, you're like 7 days a week, 7 days off. So you can have like a weekend every 7 days, which is pretty cool, which is what I'm doing, which is what I want to do. If you're a surgeon, sometimes you have to take 24-hour calls every few days, and that's just like rough. So I don't complain because I know some people have it harder than me. But generally hours are better. If you're an outpatient doctor, it's usually Monday through Friday, like 9 to 5, 8 to 5, and that's better. Yeah, but you still got to get through all of this: med school, residency, college, all these hours, right? What is a characteristic that you feel a doctor must have to be in med peds or to be part of your team? I think you need to be motivated and hardworking. Do I think you need to be a smarty pants and the most intelligent in the room? Heck no. In fact, those people suffer a lot because they just expect that they're going to know. It's the people that are hardworking. And last, you have to be very socially aware and socially cognizant. Work on your interpersonal skills, know how to talk to people, know how to be empathetic. Those are all really important factors. And I think a lot of medical schools are incorporating that into their admissions process. Okay. When do you study? I study on the job sometimes. If I'm sitting around and there's nothing going on and I've done all my work, I'll do a few questions. I love doing questions. It's so exciting. It's like seeing a patient and you get to make a decision and see if you were right, like in real time. It's so cool. Because normally if I'm seeing a patient, the response that I'm going to get to see if I did the right thing might be hours or days, right? So it's really cool to get that immediate response. And then you can apply that learning to your own patients. Okay. Do you and colleagues ever have problems reaching a consensus about how to care for patients? If so, what do you do? 100%. Yeah, I mean, I think people have different opinions on patients, but you ultimately talk it out. And what you should use is what's called evidence-based medicine. So if I say, well, I think this patient has pneumonia, I want to use this antibiotic. And if the other doctor says, well, I think this patient has pneumonia, but they also have this condition, so that increases their comorbidity for this specific bacteria. Then I'll say, you know what, you're right. I actually think that that's a better drug. So you have to talk it out and find out what's the best option. Ultimately, there is a hierarchy, right? There's the attending physician, there's me, the senior resident, there's an intern, there's the nursing staff, maybe PAs, NPs, all that stuff. So, but if you're a respectful, good doctor, you're going to take into account everyone's opinions and explain your reasoning and try to be respectful in the manner that you're conveying your ideas, right? It goes back to what I said, what makes a really good doc is those interpersonal skills, very important. Okay. Do you and colleagues ever have, what is something unique to pediatrics that makes it something you love working in? I've always worked with kids for like 10 years. I worked at like a camp for diabetic kids. I was actually a camper myself there, and I love working with kids. They're so fun and lighthearted. I also worked at my religious association for many years. I just love working with kids. But keep in mind, when you work with pediatrics, you're dealing a lot with the parents. It's not really the kid. The kids are just like, hey, they're just like playing in the corner. And the mom or the dad are like, oh, I'm freaking out. Oh, they got like a pimple on their nose. And I'm like, relax, it's just a pimple on your nose. It's not that big of a deal. They're like, well, what if it's cancer? And I'm like, well, it's probably not cancer. It looks like a pimple. Let's watch it, right? So you're dealing with the stress of the parent as well. A lot of people don't realize that when they go to pediatrics and they find out the wrong way. What does your dog do while you're working? That's funny. I have a walker for Zeus. I have a great friend. Her name's Jessica. She loves Zeus and Zeus loves her, and they play together. So Zeus does that. I put on the TV for him. He was a rescue, so he was in the shelter for like a year. Nobody wanted him. He's this 105-pound, looks like a pit bull. He's an American bull, but really tough dog, so nobody wanted him. So he now lives in this like really nice apartment, and he's got all the space to himself and no dogs. He's basically, I think he was bred to be a fighter dog, so he gets really stressed around the dog. So he gets to chill. He gets bones. He gets treats all day. I think he lives a good life. How do you find the time to exercise / work out with an 80-hour work week? Yeah, so that definitely takes a hit. I mean, you still have time, right? So if I'm waking up at 5 and getting home at 7, if I want to go to bed at 10, I walk Zeus. That's a little exercise. I go on a run with him. I can do some, while I'm watching TV, I can do some weightlifting. I have weights at my house. There's time to do all that stuff. If you guys tell me, there's so many people that are like, oh, I don't have time for that. I'm like, you for sure have time for that. Like, look what I'm doing. And then they go, oh yeah, you're right. I got time. There's 100% time. You guys just can't be lazy. You got to work hard. And the laziness isn't going to go away like super rapidly, right? It's something you have to work on. I think I'm lazy sometimes, and I used to be even more lazy. So it'll come with time. You got to work hard. And usually you just need somebody to light a flame on your butt. And that work ethic comes with time as you have more positions and you kind of, learn to grow as a human and be like a hard worker and care about what you're doing. Do you find it difficult diagnosing children as they don't always share everything that's going on? 100%. That's a really insightful question, whoever asked that. Yeah, so, I kind of compare pediatrics to being a veterinarian. A lot of times kids don't tell you anything. All you have to really see is their vitals. Are they eating, pooping, peeing, drinking normally? Are they wincing their face like this? Are they crying a lot? Do they have a temperature? There's a lot of ways that, the kid doesn't have to tell you they're feeling bad. And also for adults too, right? So being a med peds doc, I know now that I don't have to just ask my adult patients how they're feeling. I can just look at their vitals and their labs and I can tell them how they're feeling. And they go, oh, you're right, I am feeling that way. So medicine's come such a far way, and I'm so blessed, honored, and grateful to have been taught all these methods and ways to diagnose people, and I apply it every day. So yes, it's still possible. It's very much like being a vet. Okay, I'm not saying kids are animals, but sometimes they act like animals. Can you go from internal medicine to GI? Yes. So yes, you can either go to GI from internal medicine or from pediatrics. There's different ways, and both do scoping. So you could use this long camera to go through the mouth or go through the butt, the anus, and look through the gut and, look at things, take biopsies of things. It's a really cool, it's a very cool specialty to go into. Yeah, so you can go through internal medicine or pediatrics, but it's very different what you're seeing, right? Pediatric diseases can often be very different than adult diseases. So what you're seeing is very different. Okay, maybe type into Google pediatrics versus adult GI. You guys, there's so much on Google. All of you should be going on Google and just typing what your question is, and something will come up. Also, there's a lot of you in the chat right now. My Instagram is Jeremy Grossman _. I think they posted me. I love answering questions. I'm on Instagram. I'm addicted to it. I think there's a lot of good in it. There's a lot of bad in it too, but I want all of you to add me. And I am now your personal assistant in answering your questions, right? I'm not going to answer your medical questions. Well, Dr. Grossman, I've got a pimple on my nose. Is it cancer? I'm not going to answer that question because that's a medical liability or a legal liability, right? So, but what I will answer for you is my little tips and tricks or little factoids and little things about my life that can potentially help you out or knowledge from my peers. And in some instances, I'll give you the Instagrams of my colleagues who can help you out in their specific field. So please, go on Instagram, Jeremy Grossman _. I will answer your questions. I promise. I'm not Brad Pitt. I don't have 6 million followers. I will answer your question probably by tonight, unless you send it super late, because I do have a bedtime. Okay. How do you deal with burnout? Burnout is real. I think always reading up is fun. Going on UpToDate, going on Wikipedia, Google, whatever. Just reading. I enjoy reading and learning. A lot of people like read fictional books and like books about stories. I got really bored with that. I like facts. I live in facts. I'm a very rational person, so I enjoy that. That's one way I prevent burnout. I have a dog who I love, who loves me. I have good friends. I have good family who care about me. I go out. I have fun. I make sure to have activities and plan things. I watch TV. I cook. I picked up cooking recently, which I never thought I would cook. My brother Josh, he loves cooking. My mom Hillary used to always cook for me when I was a kid. Everyone cooked, and I was like, "This is real." I love cooking now. All right, so you got to do things outside of medicine. We're ultimately humans. We're not just doctors, right? We're real people too, and we have real feelings and real needs and wants. So keep that in mind. You know, it's very important while you guys are studying as college students, as high school students, as medical students. Some of you. You guys need to go out and do the things that are enjoyable to you, right? Plan out your week ahead, right? Monday from 8 to 5, I'm going to do studying. And from 5 to 7, I'm going to go out with friends. I'm going to go watch a movie, whatever. Plan your week out, hour by hour in advance, even a month if you can. And you're going to not only feel good like you're accomplishing something every day, but at the end of the day, when you get to that free period, you're going to love it. You're going to say, wow, this is well-deserved. And I don't feel guilty about taking this for myself. Would you become a family medicine physician? Heck yeah, I love family med. It's so cool. Look into the history of family med. It was like such a cowgirl specialty. So cool. It's taken on a little bit less as it used to in the city environments because there's a lot of specialties nowadays. Family med really thrives still, I believe, in rural environments where there's not a lot of physicians around. Now you have telehealth. You can see doctors virtually, which is helpful, but ultimately family docs are bosses. Really cool. I have a few good friends who are family docs. Very cool specialty. So I would still do it. In fact, I actually dual applied, so I guess triple applied to med peds and family medicine. And I don't regret it. I rank them very highly. I'm just going to answer questions, Sophia, okay? If I get to my medical slides, that's great. I think this is way more important for everyone to just answer their questions specifically because I think it applies to everyone's thinking these things. Were there any other specialties you considered before choosing pediatrics? Family med, yes, very cool specialty. ER is a very cool specialty, but you're doing with really high acuity, and you're also dealing with a lot of, excuse my French, but really lame stuff that shouldn't be in the ER. So by the time they get up to my floor, they're usually sick, and I get to deal with the sick people and help the sick people. I don't have to deal with the fluff. And I respect the hell out of ER doctors, but it wasn't for me. Those are some, again, these are all fields that are very broad, and you deal with adults and kids and different diseases. So, and I didn't like cutting, like surgery. That was not for me. Okay. How do you find yourself interacting with kids versus adults, and how do you handle kids who don't want to speak with the parents in the room? Yeah, so, you can send the parents out of the room. You say, listen, this is a normal thing that I do. I have to send them out. I think I answered your other part of your question. But essentially, you got to do your best at being a good detective and asking questions and trying to make sure everyone's comfortable, even though you're asking really, tough questions. Was there a time you thought the process of medical school was too much for you to take on? Heck yeah. Oh my gosh. I thought that yesterday. There are some days that are just really rough, but you push through because ultimately this is what you love to do. And that's why I say you guys need to shadow right now. Don't do this terrible, organized shadowing like I did, where you just hand towels and water to people. That's terrible. Go out, email doctors around you, PAs, NPs, whatever. Just shadow somebody, see what it's like to be in the field. Because ultimately, that's the only way you're going to find out if it's the right field for you, right? You're going to see hour by hour, minute by minute, second by second, what they're doing. Is that what you're going to want to be doing with your time? If you love Grey's Anatomy, maybe you should just be an actor or an actress. Maybe you should just go be a TV doctor. That's that's cool. I mean, you probably get prestige and respect, and it sounds like a fun way to go. What else is there? Sounds great. Okay. Is it okay to have non-medical experience included in our applications? Heck yeah, if it's relevant. I just scared my dog. Sorry, Zeus. Yeah, it's very important that you have non-medical experiences. For example, if you volunteered at a dog shelter, if you volunteered at a homeless shelter, if you volunteered and you're teaching kids math at your high school on the weekend, do it. Oh my gosh, yes, it's so important. Please do it. If this person or any of you have a similar experience like that, just message me on Instagram. We'll talk about your specific thing, because there are probably some things that shouldn't be on your app. So we can talk about it if you want to message me. Do you have any advice for Mcat prep? Yeah, so I use Kaplan, but keep in mind, I'm like an old dude now. I've been out of the game for a while, but there's Kaplan, and I think there's like Berkeley Review. There's a bunch, they're all good. But ultimately, when you're studying for these big tests, keep in mind that you should really only have 1 or 2 books. I don't want you having 10 books. And when you go through that book, that chapter for the first time, don't just read it and think it's going to go in your head. It's not going to go in your head. You're not that smart. You're not Einstein. Even my bro, who's like Einstein person, like the smartest person in the world, was reading encyclopedias, like when he was going to the bathroom at 2 years old. Like even this guy has to work hard, okay? So keep in mind, you have to do that as well. You have to work hard, take notes, or highlight the important stuff so that when you go back and you read that book again, you're only going to look at the highlighted stuff, because guess what? The stuff you didn't highlight, you already know. So why would you read that again? Cool. That's my tips and advice for that. How did you find research opportunities? Usually if you go to college, there's like a research pool that you can find out to look for people who need help. You can also, if you like have a professor that's teaching you like Bio 101, look them up. Look up their email, just email them, hey, I'm looking for research opportunities. And you don't have to do medical research. I did psychology research because I was more interested in that. I double majored, like I said, in biology and psychology because I wasn't sure what I wanted to do. And I just made, it ended up that the research I was doing was kind of applicable to both fields, and it worked out okay. How long do you rotate through each specialty in medical school? For example, if you knew surgery wasn't for you, how long did you have to keep doing that? You usually rotate for like 1, 2, 3 months, depending on the field, usually like 2 months, and you're out of it. But you have to do everything, right? Because even if I'm a surgery, I might work on pediatric surgery kids later down the road. So I have to know about the kids, even though I'm going into surgery, right? If I'm a neurologist, I damn well should know how to treat an internal medicine patient, right? If I don't know that potentially their infectious pneumonia could be causing their weird brain findings, then why am I scanning their brain if I didn't know that there's a whole other thing going on that I need to be aware of, right? So all of these rotations are important. It's not like we do all this for nothing. And guess what? The bio stuff, the basic biochemistry, physics, it's all like relevant. It's crazy. I've kind of flushed it out and I thought I wouldn't need it, but you do need it. It's like really applicable in what you're doing day to day. So don't think that like all this stuff you're studying in undergrad is not important, because it's like actually important. Yeah, fact check, news flash. Have you ever dealt with a parent not wanting to consent to your treatment plan for the child? What do you do in that situation? Yeah, so like even today I had this one patient whose parents were going through a divorce, super sad, and they were like bickering and fighting, and we only let one parent in at the time right now because of COVID, and the other parent was on the phone outside, and that parent was like screaming, and the parent in the room was like really concerned, wanted kids to get the vaccines, and the mom was like, oh, they cause autism, which by the way, they don't cause autism. There's no evidence out there that says that they do. Zero. So the dad's like writing down saying, please help. I think, this mom is unstable. I want to get child psychiatry on board. I really want my kid to be safe and have vaccinations. So as doctors, we have to kind of juggle. So you're not only being a medical doctor, you're being kind of a therapist. You're kind of being a mediator, almost a lawyer to some degree. So there's a lot of aspects of the job, again, which I love. I love just being more than a doctor. I love just being a helper, a general helper. And that's why it's so important. Going back to that question, it's important not to just have medical experiences. You need to have general life human experiences, because ultimately you need to be a human. If you're not a good human and you're potentially just know your medicine, I'm not going to take advice from you to help my kid if you have no idea what I'm going through. Even if you say, oh yeah, just put this on it. If you don't know what you're talking about, if you have an attitude, if you don't seem like genuine, then I'm not going to want to see you again. I'm going to go to another doctor, right? So as far as consent goes, that's a tough one. So at this point, we had to actually involve the law. We had to involve lawyers and CPS, Child Protective Services, to figure out a plan, because ultimately it comes down to mom and dad both have custody. So we don't know who could make the decision on what to give this kid in terms of vaccines. All right, another question. Nowadays, there is a law that children ages 12 and up can hide their medical history from their parents and make medical decisions for themselves. Any thoughts on that? I wasn't aware of that law. I know with teens, there's certain laws that are in place to like protect their parents from knowing about sexual history, drug use, alcohol use, et cetera, like that. I wasn't aware about 12 and up. I don't know, maybe that's a state thing. In the state of New York, that's not something I'm aware of. But again, I'm more of an inpatient doc, so maybe I'm not fully informed. So if you want to reach out to me, that person, we can talk about that on Instagram. Everyone is loving this talk. We love the transparency. Oh, that's great. I don't know if that was Sophia or somebody else, but I'm like fully transparent. And I'd like to continue being transparent online, guys. Please reach out to me, ask questions. I was so in the dark. Like COVID's been like great, I think, for everyone, because now you guys have this opportunity to, you know, speak to somebody in the field and speak to somebody who was like just in medical school and who's now a physician, but like a learning physician. So it's kind of perfect because I'm like been right there. I can kind of tell you about each stage, and I love doing it. I love helping you guys out because I didn't have anybody. So I'm really grateful and honored that you guys let us, you know, physicians like me do this. Those are all the questions far, but I'll keep sending them as they come in. Okay, so Sophia will keep sending questions. All right, so I have a case that we can talk about. I want to make sure that there's no more questions because once we get into the case, we'll get into the case. There's also maybe like 10 minutes left. This is like a long case, or fairly long case, so I can just generally talk about kind of like what happens when you see a patient. So this was a patient in the ER, okay? So this is 14-year-old guy. He's had a fever for 20 days, okay? That's a really long time. If you have a fever for 7 days, that should be concerning. You should see a doctor, okay? He went to Pakistan recently. He's had a cough. He's lost weight. He's had night sweats, a headache. He's been taking Tylenol, which lowers fevers, right? The medical term is an antipyretic. It lowers your temperature. He also had strep throat that was positive a few days ago. Sometimes that can be false, but he got amoxicillin. I guess the doctor gave him that, so good for him. Review his systems. That's what we ask all patients. So every patient I ask my general questions, but just to double check, I go through like a set list, and this is like a set list to make sure I didn't miss anything. So as soon as a patient comes in, I want to see, boom, how are they doing right away? So I look at their temperature. This is in Celsius, right? 38.1, that's a temperature, okay? Anything above 101.4 degrees Fahrenheit is a temperature, 100.4. I then look at the heart rate, which is 116 beats per minute. Hold on, I gotta show you guys this right now. This is my dog right now. He's looking so cute, just all sprawled out on the floor over here. See, this is how you prevent burnout, guys, okay? You got Zeus over here. What's up, Zeusy? Being ready for the camera. All right, back to the talk. Let's get serious, guys. We're talking medicine here. Gotta get serious. No more joking around over there, okay? Blood pressure was low, 83/51. Anything as an adult, let's talk about adults. Anything, because this kid is like older, he was bigger, so we'll treat him as an adult. Blood pressure was 83/51, which is low. And his pulse ox was okay, meaning his blood was saturated with oxygen well, okay? So he's got low blood pressure, a high heart rate, and a fever. Whoa. This is just basic stuff that they were taking hundreds of years ago, right? So we got to take it really importantly because this is how they were treating patients back in the day. We've got all these fancy tests now, but the stuff we can get like that. A lot of the fancy tests take a while to come back, okay? So the physical exam was like normal. I'll just tell you, we check their general appearance. We walk in, how are they doing? How do they look? Do they look uncomfortable? Do they look happy? Do they look stressed? Do they look tired? Do they look sweaty? Blah, blah, blah. We look at their eyes, we look at their mouth, ears, nose, throat. We look at listen to their lungs, listen to their heart, listen to their abdomen. We touch their abdomen, make sure we can feel deeply to see if there's any weird things that we can palpate or like enlarged organs, which you get trained at how to feel in medical school. Musculoskeletal. So we look to see if there's any swelling or deformity, if he can move all of his extremities, okay. His skin was warm pink. There was no rash. I'm seeing questions pop up, Sophia. So I probably will go over an hour, just a little bit, if that's okay. And then we can answer these questions at the end because I don't want to leave anybody hanging. And I'm sure all these questions are going to be helpful to everyone. And then psychiatric. That's okay. All right. Awesome. This is a cool mug I just got, by the way. It's like a rock climbing mug and you have to grip it. That's kind of fun. Burnout, guys, preventing burnout. Psychiatric wise, he was cooperative and he had an appropriate mood and affect, meaning he was interacting normally like a normal teenager, if you could even say that that's normal. Okay. Any questions? We don't have time. I'm just going to talk and present the case like we would as a doctor. Okay. What's the medical term for what this patient is experiencing? It's called fever of unknown origin. He has got a fever. It's greater than 8 days and we don't know where it's coming from. Fever of unknown origin makes a lot of sense, right? What could be some of your differential diagnoses? So every time a patient comes in, we go through all types of systems and we break it down. We can think of, okay, is this an infection? Is this a type of cancer? Is this autoimmune, like diabetes, like I have, for example? Is this a bacterial infection, viral? What's going on? What's the breakdown? And we have a system of how we go through things, okay? And we get trained in how to work through that as a medical student. And even as a resident, sometimes we need to get better training, okay? All right, so what would you do? So for this guy, okay, remember, he's got high heart rate and low blood pressure. Usually if you have low blood pressure, your heart rate's gonna go faster and faster because your blood pressure is not getting enough blood to the rest of your body. So you need to up that heart rate to pump that blood out to the rest of the body to make sure that no tissue dies, okay? So I need to give this guy fluid. He needs fluid ultimately, okay? To open up his veins, get good flow to his, and oxygen to all of his organs. I also need to give this guy an antibiotic because I think he's sick. You know, I don't know what's causing this long fever. And sometimes it can be a cancer, but like, I don't know. I just saw him, but like, he's here now. He's sick. I need to help this dude before he gets worse. So I'm going to give him some antibiotics. And then ultimately he's got a fever. So what am I going to give him? Tylenol. All right. So basically what we do in the ED is we determine, okay, can we send this patient home? Can we just help them out right now and then send them home? Or do we need to send them upstairs into the hospital to be treated for a number of days? So ultimately, we decided that this kid needed to be treated. We got some labs. His sodium was off, which is usually meaning you have low volume, low amount of fluids in your body. So, and that kind of makes sense, right? Because his heart rate was high and his blood pressure was low. His creatinine's high, meaning his kidneys are getting damaged because there's low flow to them. So that also makes sense with our initial vitals, right? Vitals are so important, you guys can see. ALT, AST, right? I'm just going through the red stuff, right? His liver function tests are elevated. Sometimes that can be from a virus. Sometimes that can be from damage from not getting enough flow. Again, consistent with our vitals, all right? And then if we look at his CBC, that whole panel on the right, the first one is the most important to me. His white blood cell count's normal. That should be elevated. If you have an infection, your white blood cell count should be up and taking care of things, right? Sometimes if you're really sick, you can be leukopenic, meaning you have a low white blood cell count, okay? I'm looking at the time, Sophie, I'm with you. How can you tell it's not a viral condition? We don't know yet. We don't know if it's a viral condition or not. That's why you have to keep searching and figuring out what's going on, okay? Here's some other labs. So if you look at the right side, all those are viruses. It's a specialized viral panel. And every virus was negative. If you guys see the bottom one there at the bottom right, COVID negative, right? So basically, he was COVID negative. So that was like our biggest concern, right? Because COVID's going around right now. And all these other classic viruses were negative. So we're like, what's going on? Normal white blood cell count, no classic viruses seen. He's got all these other abnormalities, meaning he has low fluid. So what's going on with this guy? But remember, he just went to Pakistan. Maybe we should think about that a little bit. Because that's kind of what's like standing out from his history, right? The history is so important, right? I get all the labs, vitals, imaging, cultures, whatever. But his history, what did he do? Did he have any exposures? Did he go to any weird countries where there's other organisms? Did he travel? You guys got to think about all these things, right? Is he eating weird things? Is there like an exposure to a pathogen or something that's causing inflammation in his body, like lead paint, for example, right? So something, right? All right, so here's his chest x-ray. Whoa, what is a chest x-ray? So it looks good to me. If you look in the center, that little circular thing, that's a heart. Okay, and that looks good to me. If you look at the right and the left, they look kind of hazy, right? You want those to be blacker, not too black on both sides of that heart. But it's a fairly normal chest x-ray, and chest x-rays take years and years to master and learn how to read. When I first did, I used to get so nervous presenting for all the doctors. I didn't know what I was doing. Now I feel a little bit more confident. And even now I'm like, what is this? Sometimes I have to talk to my attending and say, you know, what's going on with this patient? I have no idea what this chest x-ray says. Ultimately, the radiologist, which is a professional career you can go into out of medical school, said it was normal. So I trust them more than me. So we talked about what interventions does this patient need? I told you he needs some fluid, he needs some Tylenol for the fever, and he needs some antibiotics, okay? So he was admitted to the floors. And ultimately, we took cultures of his blood, and sometimes those cultures, which we put on a little plate, they take days and days to develop. Ultimately, it took like 2 or 3 days, and this came back with salmonella. Maybe some of you guys have heard of salmonella. Your moms and dads, your guardians said, listen, don't eat those raw eggs because you might get salmonella, or don't eat that raw fish. And they're right. You can sometimes get it from that. You can also get it from fecal oral route, meaning somebody might have touched their butt or in some way got in touch with a piece of their feces when they were infected, and they shook your hand, you shook their hand, you got some of the matter, you swiped your face because it was itchy, and then boom, now you got salmonella. All right, so there's a lot of ways that you can get salmonella. And this guy probably got it from Pakistan, where there's a lot of contaminated water. And he might have drank it and gotten it from there, right? If you look at the bottom, only 200 to 300 cases of S. typhi, of Salmonella typhi, this special strain, right? If you learn in biology, there's like two things. It's the genus and the species, right? Remember how I was saying before how important the general biology is? It's not all flush out the toilet. There's 200 to 300 cases a year. Keep in mind, there's 6,000 hospitals in the United States. That means I was super lucky to see this. I was like ecstatic. I was jazzed. I don't even use that word. I was jazzed to see this. I was so honored to be able to see this case, and now I can talk about it with you guys. So what are some risk factors? So basically, like I said, impoverished countries, poor sanitation, exposure to animals, fecal oral route, right? If you guys have heard of Typhoid Mary, that was somebody who had chronic salmonella, meaning she had the salmonella in her body and she was like, it was going out in her feces all the time. So she was the cook or the maid, something for these, for multiple houses. And so she was basically potentially touching her butt or in some way getting access to those pathogens, maybe shaking someone's hand or dealing with the food of the people that she was serving, and then they were getting salmonella, and she was passing salmonella all across the country. I believe the Department of Health at that time was trying to deal with her, but she just kept going from house to house because she needed to make money. But Typhoid Mary, look her up, interesting story, and it'll make you sound smart when you go talk to your doctors and people that you know who are in the scientific field. They go, oh wow, you know about Typhoid Mary. So there, if you look on a microscope, that's what it looks like. It's called gram-negative bacilli. So like kind of like little rod-shaped little buggers. And that's what they look like. So they looked at that under the microscope and they said, listen, this is what we're growing and this is what we think it is. And they put little kind of drips and things on it to see how it responded. And ultimately they determined that it was salmonella. There's different weeks of the illness and it can get worse and worse. So you really got to be careful. Sometimes you can get this cool kind of spotted red rash on the body. This patient didn't have it. This patient was like so confusing for us. Like I said, you can have low white blood count. You can have a high white blood count. You can have elevated liver function tests like he did. You can have inflammatory markers, which he did as well. Why was his D-dimer so high then? Doesn't it signify a blood clot? Whoa, somebody, who is that? Is that a doctor listening in? That's pretty smart. So with D-dimer is a lab value that we see that can cause clot, that can be a sign of clots that are breaking down. And a little piece goes off and we can measure that. But it can also just be something that kind of elevates when we have general inflammation in the body. So it's not specific to clots. It's also specific to anything that can cause inflammation. So you always have to take what's called clinical context. So even though I'm seeing this in my lab, I have to use my doctoring skills, my experience, my knowledge to determine, okay, is this relevant to what's going on right now? Or should I be really worried about this lab value? Okay. So that's why like a lot of people ask me, oh, should we be worried about computers taking over our jobs? I don't think it's happening anytime soon because there's a lot that goes into making medical decisions. And I don't know if computers are fully at that level or close to that level, especially in the kind of crazy cases that are super rare and weird and we don't have a lot of data on. Okay. So you still need the doctors to kind of determine things, and NPs, PAs. When I say doctors, I say everyone in the medical field. We took cultures, like I said, and we put him on antibiotics, and he finished his course. He was seen in the clinic a few weeks ago. He's looking good. He's still a grumpy teenager, and we're really happy for him. So thank you for that. That was my talk. There's another pick of Zeus. It's not an epic pick of Zeus. Go from that. Is that the same animal? Up on the floor. I guess it's the same dog. All right, so there were some questions that came up. Is there a way to rule out bacteria infection relatively quickly to avoid giving antibiotics but not necessarily potentially contributing to antibiotic resistance? Wow, there's some really smart people in the chat. So when you give antibiotics, the bacteria that are in your system can learn how to fight those antibiotics over time. and then they can become resistant. And then you're really stuck if they have an infection with that same bug later on how to treat them, because they learned how to fight all these antibiotics that you expose them to. That's what this person's talking about. So ultimately, there's not really a quick way. If you look at like the white blood cell count, you can look at what's called the neutrophil count to see if it's elevated. And sometimes that can tell you there's a bacterial infection. Sometimes there's like antibody tests that can rapidly determine. They're not as accurate, but ultimately you have to grow cultures in most cases, whether it's of the stool, the blood, the urine, the sputum, what you spit up, of like if there's a little infection on your skin, you got to take a scraping of it. Ultimately, that's what you have to do. So some other questions that came up, please guys, bring in the questions, and Sophia just cut me off when we're going over, but I want to be here to help you guys. And I'm sure a lot of you guys are already tired and sick of me talking. So, if you guys want to log off, like, I don't want to keep you here any longer. I won't be offended, but I'm here for you guys. It's only like 8 o'clock, so I can answer questions. All right. What would you say was the most impactful extracurricular you did in college? Oh my gosh, in college. I was in an academic fraternity and we did a lot of philanthropies. One of them was we had like a volleyball championship and we raised a lot of money, like 10 grand. That was really cool. We did another philanthropy where we did a clothes drive, in which we ended up giving to homeless people, which was really rewarding. What I really found most rewarding was doing with my homeless project. I think there's a Facebook page now. I think it's still going at my medical school. It's called Project Homeless Tel Aviv. You can look it up on Facebook. I think they're still doing stuff. I think it's an Instagram too. We went out and saw homeless people and we gave them resources on how to get help. We gave them food. We made them sandwiches, gave them waters. We surveyed them, asked them how they ended up what they were doing, just gave them a little bit of social interaction to kind of help push them through the day. And if we got a smile out of them, that was like a really cool thing. And that was probably the most impactful thing that I did. Are there many international residents in your program? Yes, they're all over the United States. Some of the best doctors I know are international. There was somebody told me recently that India, which has a ton of medical schools, but also a ton of people, it's actually harder to get into medical school there. So some of these doctors that come from India, and again, I'm only speaking from personal experience, they worked for many years, went to medical school, did residency, everything, and are now like esteemed doctors who even went to fellowship. And they wanted to make a better life for themselves. So they came here and they're going through residency again. They're going through fellowship again. And they're going through all that hard work again, just so they can make money and help their families out, which I think is really important. And again, just shows you what the type of people that we want in our field are people who really care about what they're doing and the positive impact they're making, not the money necessarily. These people are coming here to help out their families and make a better life for themselves. But ultimately, foreign or not, doctors are doctors. We're all here to help people, PAs, NPs, techs, everyone. I love everyone that I work with. I really have a good time doing what I'm doing. And again, it just goes to show you that just because you're an international doctor, it should not make you feel any worse at all. So many people told me, you're not going to make it. Don't do international. It's not worth it. They don't know what they're talking about. Keep in mind, a lot of these guidance counselors, they do what they do to apply to kind of like the masses. They're not really talking to you specifically. And they're also guidance counselors. So they haven't been in the field. So they really don't know everything that they're saying. So take it with a grain of salt, be respectful, hear what they're saying. Ultimately, their general advice is correct, but it's not like a tell-all advice that's going to apply to everybody. So again, if you have specific questions, please, reach out to me online and I'll answer your specific questions. Like I'm hoping to, respond. There's like 400 people of you right now. I'm hoping to respond to like 400 messages this evening. I'm sure all of you have a question and I want to answer them and help you guys out. Because again, I did not have that. Okay, there's more questions that are popping up. After finding out it was Salmonella, is it possible to send him home with instructions of care, or saying the hospital is the way to go? Good question, right? So in the ER, we're determining, do we send them home or can we send them upstairs to help them out some more? This person was doing fine for multiple days. Their vitals improved. They got fluids. They were eating, peeing, pooping, drinking, sleeping. Everything was fine. We saw improvement in their blood count. We saw improvement in their labs. We saw that their later cultures that we took after they started the antibiotics was killing off the bug. So we said, listen, this guy's fine. We can send them home. on oral antibiotics, right? He was getting IV antibiotics, right? I can't send all my patients home on IV because one, they don't know how to administer the medication. Two, what if their IV falls out? And three, it's an IV. That's really scary. Most people don't even want to deal with that, right? So once I transition that person to an oral medication, they can go home. I tell them to take 2 pills a day and come back and see me in a week, right? We don't want to lose them to follow up. We want them to come back so that we can help them out if that medication is not working for them. Okay. How often do you interact with other healthcare providers? Constantly. Oh my God, constantly. Nurses, child life specialists, techs. I'm surprised that this person knows about child life specialists. That's awesome. Yeah, there's so many levels, and I don't even like to call them levels. I like to say that we're all on the same playing field because we're all there for the patients making a difference, and we all improve their lives drastically in different ways. So as physicians, PAs, NPs, again, that whole list, we're here to kind of coordinate care, right? Especially as a hospitalist, my job is to, in the hospital, there's so many moving parts and players. I need to make sure that everything goes well for my patient. And I'm the ultimate decider of what happens to that patient. And I love that because I know that I'm going to be out there doing what's best for the patient. I don't know if all those guys out there in surgery or radiology really care about the patient. They're just reading x-rays. I'm sure they do, again, but you have to assume, you have to trust nobody. Just be the only one that you're the only one that cares about the patient. Because if everyone thinks that way, then the best is going to happen for that patient. There's going to be minimal mistakes, right? That's just a way of thinking. But I think all of my peers and colleagues are great, for the record. So I interact with them constantly, okay? And they're a huge part of my day and my life, and a huge part of my patient's life and experience in the hospital. So if they're happy, their patient's happy, and then I'm happy. So be respectful, be humble, and understand that everyone's job is important. And just because you're the doc doesn't mean you're the best one on the field by any means. In fact, people step on you the most because they want to get stuff out of you, like orders, okay? Do you have any advice for pre-med students who are applying for this cycle? Yeah, so apply broadly, USMD, USDO, international. Be open to experiences. Get the best grades you can until now. If you can't change it, that's okay. If you don't get it this cycle, try again. If you don't want to wait, apply to PA school, apply to nursing school, and then get your NP, apply to tech school, whatever. If you want to make a difference, it doesn't have to be in medicine. And guess what? If you don't want to do any of those things, go make a positive difference in the world in another way, because I respect you so much more for that. Because if you can make a decision and say, you know what, I'm going to put my pride aside, and I know I can still make a difference in other people's lives, I'm going to go do that. Okay, so that's what you can do. If you have specific questions for me, the person asks this question, or have people have similar questions, ask me on Instagram, okay? I'll answer your question. Is patient care ever limited based on what insurance companies cover? I work for a state hospital, so I'm lucky in that I get to treat all my patients. I can't really speak for private hospitals, but I imagine that I think in the ER, everyone has to be treated equally and then at least stabilized, and then you send them off. But it is it is scary. And a lot of people want socialized healthcare and socialized medicine for us. And ultimately, that's going to be up to the lawmakers and a lot of factors, economic factors that are out of our control. But what we can do as physicians is go kind of beyond our hospital walls and go into policy change, right? There's great careers like public health policy, which I'm sure some of you are a part of or applying into, that are amazing ways to make a difference. And keep in mind, I'm making a difference in, let's say, 10 patients a day, but if you can make a policy change, you're making a change in millions of people's lives every day. That's why I say doing anything to help patients is good in my book, and you're good in my book. All right. Did you ever experience imposter syndrome studying medicine? Wow, some really impactful questions there. How did you overcome this? Yeah, I think I did. I think when I came in, so imposter syndrome is when you are something, but you don't feel like it's really you, right? So usually a lot of medical students who graduate and become doctors in a day. So one day they're in medical school, they graduate, and now they're a doctor. They experience imposter syndrome, which is when you say, I'm a doctor? Are you sure? I've been a student for 10, 20 years, my entire life. You're telling me I'm a doctor? This is weird. And then you have issues with self-doubt and worrying that the decisions you're making are not the right ones. And ultimately, I think everyone experiences it to some degree. I think I was compensating for it, and I acted like I was a tough doctor when I first came in, and wasn't the best doctor I wanted to be. And I quickly changed that and was quickly humbled by the people around me. because I had dealt with people like me before. And now I'm really proud to say that I'm a doctor that I really enjoy being, and I think I'm there for my patients. I think that I'm humble and I care about everyone that works around me, and I try to make a positive experience for everyone. So I overcame it just by learning, just by understanding that people weren't responding, right? Interpersonal connections and relationships are incredibly important. You need to be able to read other people beyond what they're telling you. You need to look at their facial expressions, their body language, what they're saying, the intonation on how they're saying it, to determine, is this person responding well? And if they're not, you need to address that. Rather than hold it inside and hold a grudge, you need to address that and say, okay, yes, this patient, or rather this person is unhappy with what I'm saying. Let's discuss it. And you can't be afraid of confrontation. Okay. All right. Those are all the questions that popped up. Is there anything else that you guys have for me?
So much, Dr. Grossman. Those were the questions that have come in so far. Everyone, if you have more questions, make sure to check out Dr. Grossman on his Instagram. It'll also be linked in the description of this video. Once again, thank you so much, Dr. Grossman, for taking the time to answer our questions with such transparency and honesty, and for such a wonderful presentation overall. We really appreciate it.
Of course. Thank you so much for having me. Thank you.
For everyone watching, the Google form has been posted in the chat box, and it will be posted in the description of this video shortly. And you have 30 minutes from now to check that out. And this weekend, we're going to have our April Roundups. So that's where you'll be able to go back and rewatch all of the sessions from this month and fill out the Google form to get credit for those sessions. This will begin this coming Friday evening at 11:59 p.m. Eastern and will end on Sunday at 11:59 p.m. Eastern. And to learn more about those roundups, please check out our roundup tab on our website or our Instagram highlight. And with all that being said, thank you once again, Dr. Grossman. This was really a wonderful presentation.
Thank you so much. Good luck, everyone. Whatever you guys go into in life, just be a good human and adopt a dog if you can, okay? Because